So VLS-101 is reported here in the phase 1 clinical trial. Let me give some background of this trial. Our R1 antigen is an oncofetal protein that usually disappears before birth. But when the tumor, when some of the B cells or some of the tissues become malignant, in case of malignancies, the R1 antigen can reappear on the surface of cells. This is especially the case in mantle cell lymphoma and large cell lymphoma. So the VLS-101 is a antibody immunotoxin. So the antibody is the IgG1K monoclonal antibody that binds to the R1 antigen. But then the antibody has a linker. The linker is connected with the MMAE, is microtubule toxin, the same toxin that we use in the case of brentuximab. So this is studied in a 3+3 design in patients with large cell lymphoma, mantle cell lymphoma, and mainly these two entities. So the dose 3+3 design, the dose-related toxicities including diarrhea and neutropenia. And the dose cohort was escalated from 0.5 milligram per kilo all the way to 2.5 milligram per kilo, with a 2.5 milligram per kilo selected for the phase 2 clinical trial that's going to be open for large cell lymphoma and mantle cell lymphoma, and with the mantle cell lymphoma potentially serving as the pivotal clinical trial for FDA approval. In this clinical trial, there are 15 patients, and the trial toxicities, as we all remember, this is the first in human clinical trial. The toxicities are basically related to the MSE, to the toxin. That's what we can see together with brentuximab related studies in Hodgkin lymphoma. So the toxin related side effects including neutropenia, diarrhea, neuropathy, and very few alopecia, loss of hair. So these are mainly related to not to the antibody, but to the toxin. Please remember one specific feature of the R1 antibody antigen is once upon binding with the antibody, it is rapidly internalized, bringing toxin inside the cell to the lysosome, and lysosome then to the enzymatic cleavage releasing the toxin. So please remember that R1 is different from other antigen in its rapid internalization. So back to the toxicities. The toxicities mainly include the MSAE, as I stated already. So the overall response rate for VLS in 15 mantle cell lymphoma patients was 47%. Please remember, you may think that 47% is too low a response rate. But remember, this is after 4 prior lines of therapy. So the VLS-101 is the 5th line. So if you treat enough mantle cell lymphomas, you will see that after 4 prior lines of therapy, the patients are really near death and very terminally ill patients with mantle cell lymphoma. 47% is a very, very good response rate. In the longer term side effects, including neuropathy, some of the patients have to stop therapy due to neuropathy, and most of the neuropathy are being able to be managed. With a few that we need to stop the therapy, and mainly neuropathy is managed by dosage adjustment. So for large cell lymphoma, there was 5 patients. 4 out of 5 had a response rate of 80%, 2 CRs. So as you can see, this VLS-101 has very promising activity. It does not have infusion-related toxicities. It does not have any irritation to the vein or local tissue. Despite of the fact that we did not use any pre-medication against nausea vomiting, there was little nausea vomiting at all. So the MTD we determined at 2.5 mg per kilo, and this clinical trial is really promising.